Assalamu alaikum everyone and welcome to ECREM's R1 Bootcamp. You're listening to part 3 where we tackle teaching on shift, imposter syndrome and burnout, as well as our closing segment with resident confessions and our final advice.
Okay, so moving on to the next segment, teaching on the shift, as known as please don't ask me that. Okay, do you remember first time a medical student is just coming to you and asking a question and you're like, okay, I need to check what is this, and even the up-to-date blinked. Like,
I mean, I'm as lost as you are.
No, the best thing. Then let me give you guys some senior advice.
Okay.
So, and remember this, and try to remember anytime you asked your senior a question and they told you, read about that and let me know. Every single
They
topic.
had no clue.
Every single question where someone has asked me a question like, oh, Dr. Fatma, what does this mean? Or what are the indications for this in this condition or whatever? And I tell them, read and let me know and let's see what you know. I have zero idea what they're talking about.
Read and tell me.
Yeah. And I'm waiting for them to tell me what it is.
Yeah.
And I will act like very approving and yeah, good job.
What's next? Yes.
Which resource is this you're using? You know.
actually, Fatma, I thought whenever some attending is or the seniors are telling me this, I'm like, oh wow, they're so nice. They want me to put my brain into action. But now I know the trick.
50% of the time, I genuinely don't know what they want and I'm telling them to look it up.
Yeah.
Teaching during the shift, I think it's a very important skill.
Yeah, like how do you balance it?
Especially in the ED. I think the ED is very special environment because we all work closely together. Your nurse is around you, your registration officer, your medical student, your intern, your fellow residents, your
Right.
attending. They're right there. You're not in an office room alone, isolated from your patients, and you don't know what's going on. So because you're so close-knit and you're always around each other, it's very easy to have quick on-the-go teaching. Sometimes during the patient interaction in the patient's room, you can maybe you're doing some POCUS, and you might tell your junior resident something you see on the screen. A lot of times I will involve the patient themselves and tell them, see, this is your heart, this is your lung, this is your where your gallbladder should be. You know? But I can't find it. So if you involve the patient, you involve your junior during the shift, on the go. It doesn't have to be a thing where you both sit down and you open a resource and you start discussing. You can just say quick bits. And it doesn't have to be a full discussion about the condition. It can just be a certain pearl you want them to get out of that
Exactly.
case.
So also I want to add on to that, like, don't think like as an R1, like you're a junior yourself, like you cannot help someone else who's younger.
Yeah,
Never. Like always
100%.
have the thought that I want to teach others, because when you teach, you learn better and you remember it better. So what I like to do is tell the medical student to like follow me everywhere. Okay, so when I assign myself to a patient and we go to see a patient, I tell them, okay, come see how I do the patient approach, everything. If you have any questions, ask me. In between, like Fatma mentioned, when doing the POCUS, you show the medical student or the intern as well as the patient. So these are the skills that improves your medical care to the patient, you know?
So I wanted to add something about education. So try to remember that education is 3 main factors.
Why is your division
Everything comes in threes.
category 1? No, R2, R3. Going to R3. This is going to R3. Everything comes in R4.
It's called the rule of 3.
Yeah.
I mean, doesn't need a fourth year.
6 years.
Again, shout out to your PD.
Exactly. So there are 3 main components of learning. Always try to remember them when you're trying to learn yourself or when you're trying to teach somebody. So the first one is cognitive. The second one is psychomotor, and the last one is affective. So cognitive is the knowledge. So think about them when you're trying to teach a med student. What aspect am I teaching them? Am I teaching them cognitive, psychomotor, or affective? Cognitive is when you're teaching something medical knowledge. You're giving them concept. Actually, these 3 pearls, it's more of you learning. It's not more of you teaching, but it applies both ways. So the cognitive aspect is what knowledge are you giving them? Are you telling them something about, like, for example, a score that you use in the ED? That's
Or classifications of PE.
exactly. That's kind of something very handy to hand them. Okay, go read about NIHSS. Go read about approach to chest pain. Go read about, for example, primary survey, secondary survey. Second part is psychomotor. It's basically skills. So try to teach them how to do an ultrasound. Try to teach them how to cannulate with ultrasound. Try to teach them how to, for example, suture. All of these are like psychomotor skills you can use. Even if you think that you're not the best academic teacher, don't make yourself a bad teacher, because you could still teach a skill. We all know how to do skills. Yeah. The third part is affective, which is more of the learner's perspective. It's the attitude. So if they come into the shift with the attitude of learning, they've already won. They already gained 100%. If somebody came with that attitude that I'm here to learn, I'm receptive, I'm ready to listen and just apply whatever I'm gaining, they're 100% going to come out of their shift with something that they've learned, even if you did not actively go and teach it to them. They will grab it from you because they have that attitude. They will come and ask questions. Whenever you give them feedback, they will ask a follow-up question. You will see them actually attending to you. There are people who are like, well, I guess, I don't know. And then immediately when you see you start a discussion with them, they start to disappear. They start to fade away. I mean, you have to try to pass this to the next person. Be like, okay, have that attitude. Try to show them that you're also receptive to your attending who's trying to teach you something.
Exactly, As Fatma mentioned in the early on, that if they are motivated, you would love to talk to them and teach them.
Yes.
If they themselves find excuses to go to bathroom every 1 hour.
No, first I'll do a physical exam.
Yeah.
Are they in DKA? They're going to the bathroom every hour? No, but in regards to the attitude to learning, I've made it a habit now. Every time I have a junior resident, non-EM residents. EM residents, you don't have a choice. But every time I have a non-EM resident, like an ENT resident or IM resident or an intern, I ask them in the beginning of the shift, listen, I'll be your senior today. What is your level of involvement? What do you want it to be in the ED?
Your objective.
Because especially the past few months, a lot of these interns that we have rotating in the ED have already been accepted to dermatology or family medicine residencies.
They're not interested.
And they're not really interested. And it's unfair for myself to dedicate a lot of my time to make sure they learn about what trauma survey is, primary survey and secondary survey, when I can be spending that time charting and reviewing my patients and reassessment, and it's not fair to them when I know it's not their field of interest. So I just ask them in the beginning of the shift, how much would you like to involve yourself? And if they tell me I can do physical and history and all this, okay, that's all I need from you. And that's it.
Your attitude shows. If you coming in with like that attitude of learning, it will. I remember one of the times we had this patient who came in. It was a trauma patient, but we were avoiding to intubate that patient, although they were like having a low GCS because they're hypotensive. So it's one of those patients who you want to resuscitate before you intubate. And then the intern with me, I could see that they were really involved in the decision, why are we not intubating? I want to learn. And it's a bigger concept to try to explain an intern why we like resuscitating.
And they're trying to understand.
And it's really not. So I was like, just pause, observe everything. I'll explain everything to you in detail. They actually came back after the case was moved to the OR. He reminded me, he's like, I want to learn this. Explain it to me. Bring it. Like they bring back, that's an attitude of a learner. So that's somebody who's open to learning. Yeah. 100%. And always
the learning guided by them.
Yes. See what they want.
If they don't care about emergency medicine, they know that they want to go into another specialty. What is the point? Or at least try to guide the learning towards their specialty. If it's an intern who's interested in pediatrics, maybe have more discussions with them during the pediatrics cases that you've seen together. Focus your discussion on that. If you saw a case of tachyarrhythmia, ask them how would we approach this in a pediatric patient.
Right. And I would say spot the disruptive med student or the disruptive intern and try to not let them distract you, because some of them, their attitude or sometimes the way they act in the shift, it might distract you. Sometimes they interfere in an inappropriate situation. Sometimes their behavior kind of disrupts the entire harmony of the flow of the team. And just like what Suhaila said, don't say that, okay, I'm a junior, who am I to teach? There is always a way to teach. So in one shift, minimum, how many ECGs do you look at? How many VBGs do you look at? Just hand them the ECG and be like, okay, tell me, what do you think? Teach them rate them how to approach a reading an ECG. What's the axis? Okay, if you've got like VBG with this kind of like respiratory acidosis, metabolic acid, okay, tell me what do you see? Tell me the causes of that. That's a simple a way to start. Then when you get stuck, then you reach to Fatma's. Read and tell me.
exactly. Some of the time, not just like interns or my students, but even we get EMS students with us, and
yes.
they would be coming behind, doctor, what ECG was this?
Yeah,
And
don't forget about them. Shame. I feel like they get left out a lot.
Yeah.
yeah, but they are, I think, more excited to learn stuff.
Yeah.
Than, yeah.
And they'll need a lot of that stuff in the ambulance.
Yeah.
If, you know,
If you teach them something, it will go a long way.
will.
Yeah.
I think you guys all mentioned literally all the points. Just again, re-emphasizing what Fatma said, you know, يعني just knowing what their interest is, what their level of interest is nice, because then you can tailor your teaching and even tailor it specifically to the specialty they're interested in. So, hey, you know, you don't have to completely be uninterested. I'll give you some salient points for your specialty because we see everything, you know?
Exactly.
And even if this isn't your specialty, you're still a physician. For emergencies, someone with an emergency might come to your clinic, you know? And you're going to have to be able to recognize what a sick patient looks like. At least.
Yes.
صح?
Yes.
Yeah.
I think, you know, just emphasizing that portion to them, I think really wakes some people up,
Yeah.
you know, in terms of, okay, صح, this is not my field of choice at all, but there is something I can definitely take away from this.
Definitely a good point.
Yeah.
And
You know, we have the psychiatry residents, they rotate in our ED. So it's part of their training. And for us in SKMC, the psychiatry department is a completely different building. It's the BSP is it's really
a drive.
It's a drive. It's literally a drive.
I remember.
And we respond to their code blues. If they have a patient collapse in BSP, ED has to respond. So
you might need help yourself.
Exactly. Like if you learn this properly here, well, you are the only MD or MBBS person in that building. You need to do something until we get there to you.
Exactly.
So yeah, I mean, those things you have to teach them.
I think my final point is learn from each other.
Yeah.
You know, we're here to teach 100%, but interns and medical students have things to teach. I learn from them every day as well.
Yeah.
You know?
We're not far apart.
Exactly.
Actually, that's a very good point
Yeah.
because I feel like a lot of, let's say, trainees in general, so residents like ourselves and medical students and interns, don't also disregard other people. So don't always just learn from physicians.
Yeah.
I can't tell you how many IVs I've learned because the nurses showed me how to do it, or how to work the IV pump.
Yes.
Or where the ambo bag is, or how to connect
Set an arterial line.
exactly with
waveform,
the
yeah.
RT.
Yes.
All this.
yes,
Or the vent
100%.
settings from the RD.
This goes along with also learning where everything is in the room and where the supply closet is. But I feel like there's always something to learn from everyone. So don't focus all your knowledge or resource from your senior or your attending. Learn from anyone in the ED that will give you the time of day to teach you something. You are bound that you will use it one day.
Yeah, basically don't have pride يعني into we are all a team. Learn from everyone.
Exactly.
Segment 7, the imposter syndrome and burnout. This was me in the beginning of the R1. Am I even a doctor and what am I doing here? So do you guys have any personal red flags or burnout? And again, crying in the store is not counting as helping yourself. Also, what non-medical things you do to keep your sanity intact? And binge watching Grey's Anatomy does not count that you're studying.
I think I'll start because I feel like I've encroached on burnout this year. Early on, yani.
Yes.
I think, you know, the early signs, they're different for everyone. And it's very subtle in the beginning. You can't even tell, you know. And I think for me, it was just a feeling of, I'm not as, I guess, I was just feeling tired all the time. I remember, you know, and just thinking... Constant fatigue and just not being as excited about my shifts as I was earlier in the year, you know. And the thing is, Anna, I have like voice note diaries. Sometimes like after shifts, like I just talk about my feelings. Yeah, it's
journaling.
We all talk to
Journaling.
ourselves sometimes.
Yeah, but imagine looking from... Actually, no, I look like I'm on a phone call. Not too bad. But anyway, I think, you know... Once I started recognizing, it took me a while to realize, okay, you know, I need to address this. I think, you know, there's multiple ways to go about this. Having a good support system. One thing I wish I did more of is go to my seniors and speak to them about my feelings, you know. I think, because everyone's been through this, one way or another. And they'll give you great tips. So, you know, just having a couple of residents in your program that you have good rapport with, that you trust, and feeling free to speak to them about, you know, how you've been feeling and if they felt that way before and what they did to manage it, you know.
I think, another thing was just trying to sit down and realize, okay, why am I feeling this way? What are the things that led me here? And when I did that, I realized that I haven't had an annual in 7-8 months. And why did I do that to myself?
Yeah.
I think, again, it's because when you graduate from medical school, everything is like structured for you, your leaves and everything. You're not used to this, And internship for me, we didn't pick our annuals. They were set in stone for us. Okay. So it was my first time dealing with that. So this is a huge tip for any new R1s. Plan your annuals, Get it.
Use your breaks.
Use your breaks, man. Do it every 2 to 3 months. Schedule 1 week. You won't lose anything. You'll be a much better physician for it.
Yes.
So that's my 2 cents.
For me, imposter syndrome is something, as all like medics, we have it since med school. It's something that we grew up with. It's something that, starting with med school, you had this imposter syndrome in you. And one thing I really don't like about our environment is that we're a collection of high achievers in one pool.
Yes.
Everyone was like somewhat topper in their school. And even in their med school, they were topper to match into their specialty. So like you're really hanging around a lot of people who achieved a lot in their life.
Yes.
And like they're really like intelligent brains. So you start questioning yourself.
Exactly.
And you're like, am I really here? How did I get to this position? Am I really making the right decision?
Yeah.
I really like that you said, am I even a doctor at this point? Yeah. So I noticed one thing, that if I don't trust the learning I did and the knowledge I have, with the easiest inconvenience, I might just not, I just might just stop. The latest incident I had, I was on call with ICU. I was the ICU person and had the phone. So any call from the hospital will get to me.
Yeah.
So I get a call from one of the neurosurgery patient floor. The doctor is calling me, the inpatient. He's saying, I have a patient seizing, and consulting us as an ICU to come and see the patient in a surgical floor. So I said, okay, so what have you done so far? He's like, oh, the saturation is this. He's actively seizing. I'm like, okay, what did you give? He said, we gave Keppra. And I'm like, I know that's not the first line.
Exactly.
So I said, do you want to, did you give any benzodiazepines? And he's like, oh, well, he's post-neurosurgery and he's a cardiac patient. I know that benzodiazepine does not have a contraindication in seizure. You have to give it. That's the drug of choice. But then when he said that line, he said, oh, he's a cardiac patient. I doubted my knowledge. I was like, there must be some contraindication to benzos in the setting of a cardiac patient that I should, stop. So I told him, don't give it. And then I had to go back to the ICU consultant. He's like, no. We have to do that. We ran to the patient. We started with benzos. So it's those situations when you start doubting your knowledge. I would feel just be more grounded. Be like, I know why I'm here. I've passed a lot of exams. I've been through a lot. I really deserve to be here. And probably whatever. Don't be overconfident. But also give yourself some credit for okay, I'm thinking from what I've learned. I trust who taught me, and I trust the resources, and I'm gonna take the right decision. Personal red flags for burnout, I would say whenever I start feeling that, I'm kind of not interested to go to work.
That's the biggest one, I feel like.
Yeah,
because I feel like all of us love our job. When it starts to feel like you don't that much anymore, it means something's wrong.
Yeah, exactly.
What else, Abby?
The other stuff is when you start either you overeat or you undereat. Your diet kind of somewhat changes.
Sleeping habit.
Exactly. You start feeling like you get fatigued or exhausted really early on. I remember the first few months of residency when there was zero burnout and full excitement. You would go to the shift, you will see a cough and you'd be like, wow, I've seen somebody coughing. It's not even pneumonia, it's viral illness or something.
Exactly. No. I remember the first 3 months or something I was with an attending, and I actually got it, middle lobe, there's crackles or pneumonia, and then x-ray, middle lobe was the pneumonia. I was like, okay, wow.
You feel like a doctor.
I did it, I made it in life.
Exactly.
And my ears work. I actually detected where
my
pneumonia
stethoscope
was.
worked.
Exactly. So I was like, oh wow. And then in few months, even the trauma red was not exciting.
Come on.
Yes.
Why don't you go to SKMC?
For me, I would say that imposter syndrome is something that I still struggle with till today. And I feel like as an R1, we have a certain level of expectations, we all know, plus our seniors, right? And something that most of the programs do is a feedback after each shift. Okay, so how we are in our heads is not how people see us on the outside. You know, sometimes we might perform our best, but we think we have not done enough. So what helps me is keep myself in check, is ask at the end of the shift whoever was my senior specialist or consultant, like, what's my feedback, give me a feedback. And then they would give me the feedback, oh, you did well on this, you did this, you need to work on this. So that like helps me like keep myself in check. And also, okay, I'm good at this, I know I can improve in this, you know. So it helps me.
It validates your concerns.
It's validating. Yeah. And for me, burnout, like you all mentioned, like once you wake up in the morning, you're like, oh, I can't believe I have to go again. that's
when you know.
Flag, So yeah, take leaves.
Me, I don't like morning shifts. So for example, if I'm sleeping at 3 and I was shift at 6, I'd be like, oh that's my problem. I didn't sleep. So
the thing about burnout, it's really one of those silent things.
It's
sneaky.
You don't
It's
see
really
it coming.
sneaky. You don't see it. It's not. Sometimes you can show up just like an exhaustion, but sometimes it's really in between your patients when you are like overriding things or like, oh, this doesn't matter. Or once you start doing this is dangerous. You have to stop. You have to pause.
This makes me realize that when you say like, oh, this patient. Sometimes I realize when I'm burnt out and I'm writing notes and I have multiple notes waiting, and I think about the history and I know like I need to put this as like negative, red flag, whatever. And I think about, oh, this is not important. Then I remind myself like, no, this is a patient, this is a life. If anything, this documentation is important. So just be aware of like what you might do, you know, to cause harm to yourself and to your patients. Yeah.
So aside from like taking leaves, what else you guys
You can
do
speak to your friends, family, you know, do what you
do
like.
something outside of medicine that
go for swimming, cycling. That usually helps. Exactly. For me, what the thing is like, and this is obviously a suggestion for the newcomers as well, I never realized that I'm actually burning out until one day in one of the academic days we had a lecture from a psychologist, and the way I was answering to her was picked out of my PD. Shout out to Dr. Sanjay. And he goes like, we need to talk after this. What's wrong with you? And then I remember we spoke for like half an hour, 45 minutes, and then he gave me leave and he gave me tips like swimming and cycling. He was like, you need to go.
He's the best.
Yes, really.
And I think, finding your happy place, whether that's a hobby, whether that's family and friends, you know, just whatever makes you happy, or a small, I think something that you can do daily that's small and that keeps your peace is also like a strategy to help fight against burnout, maybe.
You know, one thing I found that really helpful, this applies to both if you want to learn something new and also if you want to detach from burnout. If you want to really detach from the burnout, or if you want to learn something new, try to talk to somebody outside of that field. For example, you're trying to learn about, for example, heart disease. When will you be more at more like knowledge? When you explain it to another medic who knows the same thing, or when you explain it to a non-medic? To a non-medic, because you have to start from really the
basics.
The basics. So there's a heart, and the heart has vessels that they supply the walls of the vessel. Like, you don't have to say this to another medic, but no, you have to say it to somebody who's out of medicine.
Exactly.
So it really digs deep into the details. And also in return, the questions they start asking you are like questions that would really start going deep into
challenging
the
you.
Challenging questions, because what might seem obvious to another medic would not be obvious to this person. They'll start asking you, why does the heart have vessels itself? Why would this plaque form? What's the reason? What are the risk factors? Like, you know, you start digging deeper. The same thing goes with burnout. If you feel like you're burning out, try talking to a non-medical person about it. Like, that goes to your family if they're not in the medical field, or to your friends. Like, they would see you down. They would you'll have that moment with them. Say, okay, so this happened. You don't have to mention patient details. Or like what you work information, but try to talk to them. Do like this kind of like decompression from your chest. Be like, oh, it's been rough lately. I've had this multiple sick patient who I think they affected me. So be like, okay, you see the questions they start asking you, especially if there's one of those like, you know, high IQ, socially intelligent people. If you have them in your life, please grab tightly into them and then try to have that conversation. Trust me, after that conversation, you will feel like really recharged, because it will ground you, like what Fatma said. It will make you go back to your roots. Okay, I'm doing this for a reason.
My advice regarding burnout, because I feel like maybe, not to toot my own horn, but I might have the most experience as a resident, so I might have gone through this the most.
Yes.
First of all, I think of burnout as like an infection, as a disease.
Yeah.
First of all, recognize the signs of it in yourself. It might not be the same as other people. Recognize what causes the burnout for you. So it might be different things. And the solution might not always be the same for everyone. Someone might say, oh, if I take annual leave for a few days, I feel better. But for example, certain people feel like it makes their sensation of dissatisfaction worse because now they enjoy life and it feels worse going back to work.
Oh, yeah.
Exactly.
That's true too.
So
actually.
figure out what helps you and figure out what the triggers are. For me, for example, it's the constant decision making and the empathy fatigue during the shift. When you have to talk to 20 people in 8 hours saying, I'm sorry you feel this way. I know you're in pain. By the end, you have zero empathy left. You might see a person dying right outside your apartment door, and all you can think is, "Please move. I need to go inside." Right?
Yeah.
I'm
You're
not on
not
shift.
in that. You're not in that headspace anymore to give any more out empathy to other people. So figure out what those triggers for your burnout are, and minimize them as much as possible. And have some like red alarms. Like an infection. CRP is getting higher. I'll tell myself, Fatma, you're becoming a bit more irritable during the shift. This is one of your signs that you're not enjoying your time and you're feeling dissatisfied. Figure it out. And figure out what helps you. Time off work might not be the best for everyone. So figure out what's the best way for you and talk to other people like Amin said, talk to other people who've gone through burnout and talk to people outside of medicine that can give you a fresh perspective. When you talk to your friend that has to send corporate emails at 10 a.m. every day and go to board meetings, it makes it feel like, wait a minute, maybe I am lucky. I get to stick tubes down people's throats, and not sit in a board meeting for 3 hours talking about marketing agendas and
leaving thinking this could have been an email.
fiscal years and all this, right? So get a fresh perspective. The world is way bigger than our specialty. And when it feels like that, it's better. Regarding imposter syndrome and also a little bit about burnout, for me, it's very difficult to talk to other people. I think it's pride. That's what I think. And like Amin said, we are mostly high achievers, highly intelligent people. It's very hard to trust someone else other than yourself, right? I think I'm the best person to talk to me. Why would I talk to someone else? So I've made like a tiny trick for myself. Maybe it's acute psychosis. I don't know. I have an alter ego called Sumaya. I talk to her.
Oh my God.
Yes, you mentioned it.
We need someone to clear the patient.
Yes, it was mentioned before. Yes.
For me, it's like a little mental exercise. So it's very similar to what Suhaila was saying, that if you feel like maybe you are not at the level you should be and you're starting to feel those thoughts about being an imposter, you don't deserve to be here, talk to Sumaya.
Yes. Okay.
Which is you. Approach yourself in a truly objective way. Tell yourself, if I'm now another person and I'm looking at my fellow resident and this is their performance and this is what they've done and this is what they do and this is how they act and this is how they run their shift, would I commend them? Would I criticize them? Would I give them some advice? It helps you understand yourself better, especially if you take it as a way of someone else. I would tell myself, okay, if my fellow resident, for example, Sarah, said this, would I think really that she's not a good resident? If I might get rejected about my score in an exam that we did during academic day, if I tell myself, oh, if Sonia came up to me and she said she got a 53 as well, would I go like, oh, Sonia, she's such an idiot. She should not be in the program. She's a bad resident. But this is what we tell ourselves.
That's what we do.
So why is it okay to tell ourselves that, but we don't accept this for other people?
Exactly.
So bottom line is be kind to yourself as you would be to your fellow resident.
Right.
Yeah.
And someone said, if your life is a movie and you're the main character, what would be the audience? What would they be screaming for you to do?
Go see Psych.
So listen to that in your head and go do it. Like if in your head the audience are saying like go take a break or go do something, go do it. And I would say the best therapy for any disease is prevention. So you have to prevent the burnout. We have to do more of like try to do in your residency more of education about burnout.
Definitely.
Approach your other residents. You can do a small session. I don't know about other programs. In our program we have a wellness coach. So she is, shout out to Dr. Arwa Breki. She's a life coach outside of medicine. So she's a trained personal coach and she does sessions actually. And she's also the wellness person in our hospital. So she very frequently comes up and she gives us those, not a straightforward traditional lecture. She tries to make it very interactive. It's like a workshop. So she gives us like papers where we have to like exercise with the person next to you, do this exercise, figure out what type of personality you are, figure out what level of burnout you are. Those things, they really go a long way, especially if you do them at like frequent paced intervals. So they try to keep everybody in check, just like what Sonia said. When one of us is like, a red flag is like, beeping, is like, you have to go and take a break. Talk to your people. I'm sure a lot of
you can't fix what you don't know.
Exactly.
Yeah.
So the closing segment. This is about our confessions and more laughs. So before we wrap up, this is a speed round. Weirdest thing you have said out loud on shift. We'll start with Suhaila.
Weirdest thing I've said out loud.
Others can think about it.
Maybe like when a patient comes in and I like from the vitals and everything, they're vitally stable and they come like their complaint is like fever or flu. And I say out loud, just a flu? Like, I mean, hopefully the patient didn't hear me, but I think that's something that I shouldn't have said out loud, but yeah.
Me, I go like, I have flu. I'm looking for you. What are you doing?
Yeah.
But which is wrong,
Yeah.
I think weirdest thing I've said out loud on shift was consult to talks. I was saying, yes, this patient fried fish in diesel. Yes, it was accidental. How? Long story. Stay tuned.
Wow, I didn't know that.
It was bad.
Yeah. For me, I had this.
We'll have so many.
Oh my God. I have two. One is in a shift. One is in a how would you say it? In an M&M.
Okay.
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 All right. So the one on the shift, I had to go and explain to a patient that they had a scissor in their stomach, forgotten from a surgery they had 15 years ago.
So this is not a Bollywood movie. This is reality.
Oh my God.
Okay.
Yeah. So they had like a surgical clamp actually.
Oh.
The patient was significantly obese, and they just got on a plane and traveled from a country and arrived in Abu Dhabi. And during the flight, they were just so uncomfortable. They already have like a very high body habitus, high BMI, and they got so comfortable on the flight. And then they landed and they came to the ED, and we did like abdominal X-ray, and then because we were thinking constipation or something, I don't remember what was the indication to do the abdominal X-ray, anyways. I mean, it's something you should be against. Most questions.
Now he's like, what did I just say?
Yeah.
Abdominal X-ray.
Yeah, and then we found this giant surgical clamp in the X-ray, and then we're like, wow. We go back to the patient first cautiously and ask them what happened, and they said, yeah, I had this surgery done like few years ago, like 15 years ago. And then you have to go and tell them that person forgot the clamp. I mean, it can happen to any surgeon.
Exactly.
We're not trying to throw blame, but it's something really weird to tell a patient.
Yeah,
and then have to tell them that this thing exists in your belly, and then you have to probably they have developed adhesions on top of it or something. Yeah. The second weird thing I said, I was in an M&M when I was an intern. I was attending the emergency medicine M&M. And then the M&M case was this 3-week-old that came in with fever and got discharged without a septic workup. And then the patient eventually had the meningitis. So, like any below 1 month or like 60 days infant
Septic
with fever,
workup.
this is like a big, red flag. And they were having this hot discussion, like how did this patient get like be discharged and all. And I was like, at a point, I was like, what's the fuss? It's just an infant with a fever. I'm like, I didn't get the fact that, like, why are you making such a
Why
big...
are they crying?
Like, why are you crying? Like, he had a fever. He went home, like, give him paracetamol and he's fine. Everyone just looked at me, he's like, he's fine.
You will love me.
Join ED, then we'll talk about it. Anything, Fatma?
Nothing, actually. Nothing comes to mind. I mean... There's the classic, like, things you might say that you realize later is very strange. Things like, for example, I play lots of video games.
Yeah.
a lot of the online phrases, sometimes I end up using in real life. One of them is an acronym GG. It means good game.
Yes.
So you say it and then, or you say it. Yes,
I
I did.
actually heard her saying Gigi and I was like, what?
Or you say it to mean something like game over.
Yeah.
So one time I was like telling a patient because she didn't want to come in the hospital and she's just been discharged and all this. So our main differential was a healthcare associated pneumonia. So I was like, well, we'll get your labs, we'll see, but I think you need to come in. And she's like, no, please, I don't want to come in. Well, then I just like referred it to the labs. I said, we'll wait for the x-ray in the labs, and then if something shows up, I'm sorry, but you have to come in the hospital. She said, okay, we'll wait for the labs and see. Okay. I go, labs show pneumonia. She's getting admitted. I go back to her. I'm like, Gigi, I'm sorry, you have to come in the hospital. And as soon as I said that, I realized even it was so strange. I don't think she paid attention to what I said.
But you
I said
had
it.
mask on.
Yeah.
She was like, I misheard.
Exactly. I said it in Arabic. يعني that Gigi أنا آسفة بس لازم ندخلك المستشفى. So it was very strange.
Very confused.
No, as soon as I left the patient's room, I realized I might be spending too much time online. I need to find another hobby.
Yeah. I agree with that. Spending too much time online. I agree. Sometimes I speak to patients using TikTok slang when I'm like, okay, I need to like pause and like realize. Or when we discuss something like amongst each other on the workstation, and my senior will tell me like, oh, you know, the patient had a STEMI or something, and then they just went home. I'd be like, that's crazy.
Yeah.
You know.
Yeah, it's not for me, it's a phrase for me. It's this Korean heart.
Oh, yeah.
Japanese
I am.
heart.
Yeah.
So I have a story to share, and Dr. Graham, shout out. This I have repeated so many times back in our academic days, but I was showing him this heart because he's one of the best we have, and he understood for something else totally. And then I had to explain
He
to him,
thought it
Dr.
was like a vulgar gesture or something.
Exactly.
Your guess, يعني, بس
Yeah.
But then why would I do this to him in the shift, and between so many other consultants, and but then I'd explain to him it's a heart, and then he's like, now we show it to each other as a
Yeah.
so this
Speaking in the Gen Z and the terms and signs is just sometimes it gets you.
Exactly.
I remember like one patient came in and then he's like, crunching his chest, and then he's just complaining of chest pain, and I'm just looking at my like colleague and I'm like, oh, it's giving STEMI.
I think I actually said that in a consult once. It was not okay.
It's giving. The vibe says.
Exactly.
We go with vibes.
We're going with vibes. This vibe is not nice. Yeah, exactly. Yeah.
I don't think he needs ICU, but I'm not happy with his vibe. Please come see the patient.
Exactly. Yeah. What's the funniest patient complaint you guys have heard?
Oh, I win.
I think I won.
Okay.
Okay. Yeah. I mean, it's very confident, so I might not win actually.
No, we have bets on you. You will win.
One time, a guy he came to the ED. It was a night shift.
Yeah.
The zone was busy, so we saw him in resus.
Oh, wow.
And I'm like, he's a middle-aged man, previously healthy. He said, I have left toe pain at 9 p.m. every day for 3 years.
And you decided to come to my shift so I can fix your 3 years.
I think she wins, but
This is exactly what I documented. Left toe pain every day at 9 p.m. for 3 years.
And we saw him in research.
That's a hallucination. It's not
And there was maybe a 30-second pause where I'm just looking at him and I pretended to look at the toe. But genuinely, in my head, it was just circus noises because I didn't know what to do at that point.
Moment of realization.
Yeah.
You had the life check.
Exactly. At that moment, I wished we had a more critical patient. That would be easier to handle than this. And I kept tracking my brain. Why 9 p.m.?
Yeah.
There must be an
At
association.
9 p.m. he felt it.
Yeah, but why 9 p.m.? I'm
This will
like,
make such a nice board case, oral boards.
Oral
For communication.
it will be something like there's a magnifying glass in his room, and at 9 p.m. exactly they turn off the lights, so the light from the other lamp
Oh my
focusing the light on his.
Suddenly you're
Can you tell that I thought about this a lot the past 2 years? I have many theories.
I wonder if he still has the pain.
Yeah.
I have no idea. I never saw him again. Maybe I should have gotten his phone number, checked up on his toe.
Yes.
I don't know.
Yeah, you should
And
have.
all of these weird complaints, they come like at weird times.
Exactly.
Like you come.
You know, actually, they think they're gonna die because of this, so they just come.
It's anxiety. Yeah.
Yeah.
That's why he came at 3 a.m. He's like, the pain didn't stop.
From
Usually
nine-
it stops,
it stops.
but since
Today
9
it didn't stop.
continuous. And
Yeah.
that's why I came. Figure out what's wrong with my toe.
Exactly. And then we have patients almost dying, and they're like, "Oh, we thought we were just okay."
Exactly. It's either zero.
Yeah, yeah.
I just drank water, it's fine.
Yeah.
Exactly.
Dissection.
Exactly. Yes, I mean.
Yeah.
I had a patient, 19 years old, came in for voice change.
Okay.
Oh, not
So
bad.
I'm like, wait, is this
Cyclotypus?
stroke? I'm like, wait, is this like aphasia? Is she's like dysarthric?
Yeah.
What's happening?
19 or 90?
19.
19.
1-9.
9. Okay.
1-9. And I'm like, what do you mean voice? And she's just speaking perfectly normal in front of me. I'm like, what do you mean? Like, how do you do
Like
Socrates on her?
hoarseness?
Yeah, not hoarseness. Just my voice changed. I'm like, what do you mean? She's like,
okay.
أحس اليوم صوتي اتغير. I'm like, what do you mean your voice has changed? Like, how does it sound different? I'm like, yeah, she
Exactly.
just sounds different.
Maybe ears are blocked, so her hearing,
God-
she
God
hears
knows.
herself different.
She's like, the way I talk is just not the way I don't feel like myself today. I'm like,
Please tell me
how
the
do I
solution,
work you
please.
up?
Yeah.
What do I do? Do I activate stroke code?
How do I even document this?
Exactly.
What do I say?
How do I take Socrates site onset radiation? Where?
Is it higher pitch or lower pitch? You know, like
Yeah.
Do you have old recordings of your voice I can
Yeah, I
compare?
can compare. Yeah, exactly.
Exactly. Yeah, that's. Yeah.
I like it. Comparing ECGs and Can I hear your voice notes on your WhatsApp?
Can you open
that's you. You're like,
her yelling at her younger brother?
For 30 minutes.
I mean, would have
That is strange. Yeah, that's
Yeah.
very
strange.
and something you don't know. Like, how do you come up even with a differential for that?
Approach to
Exactly.
voice change. New chapter.
Ask Rosens to add this. as
Exactly.
Please check Rosen's next edition for Amin's chapter.
We'll also do one for you. Approach to toe pain at 9 p.m.
Yeah. خلاص, me and
You should
Amin
name
will
this
start
section
writing.
Approach to toe pain.
Approach to approaches.
Weird approaches at 3 a.m. Okay. Anything else by Suhaila or Sheikha?
honestly, a lot of
Why we don't have fun like this in our shift?
I've had a couple of funny stories, but I can't remember now.
I know, me too. There were a lot of moments where, you know, you're like, is there a hidden camera somewhere? And you're like, is this real? You know?
Yeah.
I just, unfortunately, nothing comes to mind at the moment. But
I had a weird
wow.
case of a patient, but this is not like a funny complaint. It's actually true, and it's a complaint, but it happens very frequently. That's why it's really weird. A guy who would come like every other night shift with jaw dislocation.
Oh.
And the thing is, he works at the night shift. He's like a security or a police officer who works at night. And whenever he's on a night shift, he yawns. And whenever he yawns, he dislocates his jaw. And then he just comes to the ED. And
Stop yawning.
Stop giving him night shifts.
And if you open, like, he has multiple encounters for jaw dislocation. It was reduced. They do the procedure sedation, reduce
You
it.
know, we actually don't have EPS for jaw dislocation. We would have filled it completely.
I swear, yeah.
That is very strange.
It's very strange. And it comes like every other night. Yeah. He even had one encounter where he came after eating a burger. So he attempted to eat like a giant
I think that Burger King Whopper or something, yeah.
خلاص, stop yawning.
Stop eating burgers.
Only drink soups.
You will lose
Stop
weight.
diet.
خلاص.
Yeah. Okay, guys. So if EM residents were animals,
Oh my God.
what would you be?
What? I would be.
Wait, what would we be like as an individual, or what I think ED?
No, individual animal.
Okay. Individual.
Individual, yes.
That's very
I mean, you could be looking for snacks as an animal, like.
So I have a good one, but I think this is for all ED specialists and ED
You mean
people, my people in general.
Okay.
We are bees, I think.
Ooh.
Bees.
Yes.
You need to explain this.
First of all, we're addicted to sugar,
Yes.
and we look around for it everywhere,
Oh, yes.
and we find it in the rarest of places. Second, we hold up basically the ecological system of the planet,
Right.
and we hold up the healthcare system as ED physicians. We're the first lines, and we manage lots of uninsured people, vulnerable people. people who don't have direct access to healthcare in our ED. Second of all. Third of all, we're very hardworking. And we are known to work all around the clock.
Yes.
So I think we are bees.
Wow, that's a great explanation.
One other thing about bees, usually the hardworking bees are the female bees. See, I'm saying this. See.
I mean,
I mean, just got approval from all females.
we all approve.
We just impressed the whole EM ladies available.
I would like to shout out. I mean,
By the way, I mean, just letting you know, we are 13 residents now. 10 of us are girls.
Yes. I'm only saying this because they're dominating the field. That's why. I don't want to be kicked out like a male bee.
No, listen. 10 of us are girls. 2 of them are graduating. The new 4 are also just girls.
Oh my
Welcome to SSMC.
Yes. In our program, only 3 male residents out of 17 also. Same thing.
yeah.
Also, our departments are like really heavily like female attendings.
Yeah, so this goes completely, I'm sure Zaid military also females, we are dominant.
so yeah, I think we're bees.
One last thing. This should be in a sentence or a 2. Your last piece of advice for the fresh baby residents tuning in. Funny, real, slightly unhinged, anything. To summarize our whole.
Be you, do you, and be good. Yeah.
Amazing.
Yeah.
Couldn't have said it better.
Just give each period of your residency its full, enjoy the moment fully. Give it its full attention from yourself. Don't rush things. This is a journey. Enjoy it. That's number 1. Number 2, look to your seniors. They're the biggest resource you have for advice, knowledge, advice on how to handle burnout, how to see it, how to prevent it. So use your seniors, your mentors, and your colleagues. And always, like I said in the beginning, remind yourself of why you're doing this, why you chose this, and why it means so much to you. Yeah. That would be my advice for them.
That's a good one.
I think just a reminder that you deserve to be here. You went through a lot of exams, a lot of interviews, a lot of self-doubt. And, the PD chose you and the whole team chose you for a reason. So, please don't doubt yourself. There's going to be a lot of hard moments this year. It's a steep learning curve. I mean, I think internship, yes, you're a physician, but now, you're training to be the physician, you want to be in the future, in the specialty you choose, right? It's a steep learning curve. It feels like a big responsibility, but, your seniors are there for you. Have a good support system and, try not to bottle things up. We're all really proud of you and can't wait to see what type of physicians you all will become, inshallah.
Yeah, well, I can't add anything more to what you guys said. If there's one thing I'd leave with everyone else is try to remember that you are part of a very unique specialty. You're very lucky to be like in this training position to become one of those very unique specialties. Also one of the youngest specialties to be born. We are one of the youngest specialties. You're a collection of everything. You are a mixture of everything. You're so colorful. Also try to remember that everybody is jealous of the kind of patients you see because we look after the most interesting 5 minutes of each specialty.
Yes.
We look after the sick cardiac patient, the sick palm patient, the sick derma patient, the sick psych patient. We see it all. And just like what Sheikha said, a lot of the imposter syndrome that you might go through, it might get to you. So try to validate yourself. You've done hard work, which is really hard enough to put you in this position. So respect that by looking after yourself and respecting yourself by also going and reading and learning and trying to grow. Give it your 100% on everything that you do. Put it your all. Put your heart into things. Don't do things blindly and enjoy it. You'll be great.
Enjoy it. Yes.
And just remember, no matter how hard it gets, things will always get better. It always gets easier. And remember that you have a support system with you. Your senior residents, your specialists, your consultants. So always be open to ask for help whenever you need it.
Shout out to Sumaya. You helped me so much. I'm going to miss her.
Also, before finishing, our seniors, the R4s, are graduating soon. They have their oral boards coming up.
Yep.
So we wish them all the very
All
best.
the best.
They're going to do great.
Yes.
It's all the 4 years of hard work which has come to this finally. You guys are going to do great. You guys are great physicians already.
100%. Yes.
And yeah, we'll all pray for you.
Yes, inshallah.
We're
All
so
the
Thank you so
best,
much.
all the best.
Good luck, you
Good
guys.
luck. All the best. You'll crush it, inshallah.
Yes, inshallah.
Thanks for tuning to ECREM Talks. To all our EM residents out there, stay caffeinated, stay curious. And remember, if all fails, just start with ABC and fake confidence until the attending walks in. See you in your next shift.
See you.
See you.